The topic of my lecture is femoral neck fractures or cervical hip fractures. And I'm briefly going through the objectives here. The first, the classification, then the evidence for treatment of undisplaced fractures, some main parties of the evidence for treatment of displaced fractures, and limitations of meta-analysis, and finally my personal interpretation of current evidence. I'm just going to fix this. Before I start, we have to look at the most valid and best classification, and that is the Garden classification, which divides the fractures into 4 types, Garden 1 to 4. And since there is no differences in outcome comparing Garden 1 versus 2 and Garden 3 versus 4, we nowadays classify the Garden 1 and 2 fractures as undisplaced and Garden 3 and 4 as displaced. Moreover, it's very important to remember that the Garden classification is made only by assessing the frontal view, that means the anterior-posterior radiological view. A valgus impacted Garden 2 fracture may have some dorsal angulation and still be classified as an undisplaced fracture. So the undisplaced fractures constitute 25 to 30% of the fractures and the displaced 70 to 75%. There is no meta-analysis on undisplaced fractures, but I made a review 2002 on those studies available at that time, and based on 10 prospective studies including 900 patients, the rate of non-union was approximately 5% and avascular necrosis 6%. That gives an overall fracture complication rate of 11%. And most previous studies have shown acceptable function and quality of life for patients with uneventfully healed undisplaced fractures. So the treatment for an undisplaced fracture is generally internal fixation. And the exceptions are rheumatoid arthritis, osteoarthritis, and of course a pathological fracture. However, there is a recent study challenging this opinion, and that is the study by Rugmark from 2009. Undisplaced femoral neck fractures, no problems, question mark. A consecutive study of 224 patients treated with internal fixation. And they showed a reoperation rate of 15%, and 11% were considered as failures, and that's the same figure as I got, and mostly were avascular necrosis. 9% had a secondary arthroplasty, and 40% stated that they had mild or severe pain while walking. However, it still remains to investigate whether a primary arthroplasty would give a better outcome. And up to date, there are no prospective randomized trials comparing internal fixation and arthroplasty in this patient group. And now to the main problem, the displaced fractures. And regarding these results after internal fixation, there is a well-performed meta-analysis from Lu Yao, 1994, and it's based on 106 studies including more than 6,300 patients. And the non-union rate was 33% and the rate of avascular necrosis 16%. That gives an overall fracture complication rate of 49%. And there is no well-performed study with at least 2-year follow-up that have a complication rate lower than 36% in the literature. Regarding the choice of implant, there are 2 meta-analyses, one from Parker, 1999, including 4,900 patients. And the overall conclusions were that screws appeared to be superior to pins, but it was not possible to determine the number of screws, but at least 2. And no advantage was shown for an implant with a side plate. As some of you probably know, there is a sort of new idea that the side plate would give better results even in femoral neck fractures, and that's not confirmed in the literature. The second meta-analysis is from 2003 from Cochrane including more than 5,500 patients from 28 studies. And this is a more critical review, and it was not possible to draw any firm conclusions. And the reason for that was that the few significant differences observed may have arisen by chance, and this taken in conjunction with the generally low quality of the included studies, no definitive conclusions could be drawn regarding the choice of implant. So the implication for practice is that the differences in failure rate related to the type of implant is small, and at the present time it's not possible to determine the optimal implant for internal fixation. And the implications for research is that future studies should, of course, be adequately powered to detect any clinically important differences between the implant types. And based on the previous small differences shown, these studies must include thousands rather than hundreds of patients. So rather large studies are required to solve this question. Internal fixation versus arthroplasty has been analyzed in meta-analyses, also from Cochrane, last updated 2006, including 2,700 patients from 17 randomized trials. And today, outdated implants are used in a number of these studies. The Austin Moore prosthesis was used in 3, and the Christiansen prosthesis was used in 2, and that's a problem with meta-analysis. And the implication for research is clearer in this review. For practice, internal fixation is associated with more prevalent hip complications and more frequent reoperations. So 36% versus 11%. There were no differences in mortality rate, and pain and function appeared to be better after a cemented arthroplasty. And they also have an implication for research that future randomized controlled trials with full reporting of final outcome measures and adequate length of follow-up. That means at least 2-year follow-up. And they also say that studies should be undertaken to see which particular groups of patients would be better treated by either method. For example, the younger patients, we don't know the age limit when we should start doing arthroplasties. The very elderly frail is also a group like that, or the severely cognitively impaired patients. I come back to that problem. Regarding the type of arthroplasty, there is a review updated last year, 2009, and 6 studies included almost 900 patients, compared the uncemented Austin Moore prosthesis with the cemented prosthesis. And generally, patients with cemented prosthesis had less pain and better mobility. And the result of the largest study made by Martin Parker himself, with the strongest methodology, including 400 patients, was strongly in favor for the use of cement. 7 trials, including more than 850 patients, compared a bipolar hemiarthroplasty with a unipolar, and there were no differences demonstrated. 7 trials, including more than 700 patients, compared different types of hemiarthroplasty with total hip arthroplasty. Most of the prostheses in this study were cemented, and there was a trend towards better functional outcome after total hip arthroplasty. Only one study compared a modern uncemented hydroxyapatite-coated arthroplasty with a cemented arthroplasty. And that is the study by Figwood from last year, including more than 200 patients randomized to cemented bipolar to a hydroxyapatite-coated bipolar. And the outcome was essentially the same in both groups. But in other studies on modern press-fit fixed uncemented implants, there is an acceptable high rate of perioperative or early postoperative fractures for uncemented stems. So, something about the limitations, especially relevant for this particular field of research. As I said, meta-analyses usually include all available studies. That means also older studies using outdated implants, for example, the Moore prosthesis and the Christiansen prosthesis. And that's a problem, of course. Secondly, the type and severity of the complications after internal fixation and arthroplasty are very different. After internal fixation, the most common complication is fracture healing complication, of course, followed by compromised function due to femoral shortening and local pain due to hardware, while deep infections are rather rare. After an arthroplasty, dislocation of the prosthesis is the most common complication, while deep infection, periprosthetic fractures, and loosening is rather infrequent. Finally, and this is the most important limitation, that the aim of a meta-analysis is to find one single method for the treatment of all patients with the same type of fracture. And that's not possible in this population, because this population of elderly with femoral neck fractures comprises several subpopulations, ranging from the lucid, healthy, active, independently living patient with a long life expectancy to the institutionalized, bedridden, and cognitively impaired patients. So, modern treatment should be based on an individual assessment of the patient's profile. That means age, and with age we mean expected survival time, preoperative walking ability, functional demands, and risk factors. And one important risk factor, for example, is cognitive dysfunction. And internal fixation, unipolar, hemiarthroplasty, bipolar, and total hip should all be available in our treatment of these patients. Finally, my personal interpretation of current evidence, perhaps evidence level 7, as said, stop using the uncemented Austin Moore prosthesis. I know it's still used in Sweden in some places. It shouldn't be used. There is very good evidence not to use the Austin Moore prosthesis. It's an outdated implant. Patients with undisplaced fractures should be treated with internal fixation. And according to current evidence, I see no reasons why to abandon the use of 2 or 3 screws or 2 hands-on pins. There is no evidence that there is something better today. Young patients with displaced fractures should be treated with internal fixation. However, the upper age limit remains to be determined. Perhaps we will end up in the range 55 to 60 years, and that's lower than most of us currently use. Most of us, I think, have the limit of 65 or 70 years. But I think we should go a little bit to younger patients here, because the complication rate after internal fixation is as high in younger patients. Most elderly patients with low functional demands and short lifetime expectancy should be treated with a cemented hemiarthroplasty. Whether it should be a bipolar or unipolar remains to be determined. There are some studies coming up. Perhaps they will give us the answer. And finally, elderly patients with displaced fractures and high functional demands and long life expectancy should be treated with a cemented total hip arthroplasty. I don't think this is very controversial. Thank you.